invite Dr. Sanjeev Rao sir and Dr. Rajshekhar sir to moderate this session.
Good afternoon. I think you're all hungry. So as Dr. Thomas said, stay hungry, stay foolish. So you should all be hungry, for more knowledge and this thing. I thank Dr. Amresh for the opportunity and the Nizam's team for the wonderful arrangement. Pediatric cardiac surgery is very interesting. Of all branches of medicine, I think this pediatric cardiac surgery would have added maximum number of years to life. So that way it's very satisfying discipline, but sometimes as said, you can face up unanticipated problems. As Dr. Rajshekhar was telling, though most of the surgeons are skilled, why the reason why most surgeons don't take a pediatric cardiac surgery is that you lack a proper team. You don't have patients you don't have people to look after your post-op patients. You don't have correct cardiologists to give you the correct diagnosis. So if you want to be a pediatric cardiac surgeon, I think the most important thing is that you should learn to work with a good team. And in addition, you should have very good communication skills. I think Dr. Rajshekhar has also said that one of the most important skill to reduce all the complications of CPB and other thing is have a good communication with your perfusionist, and also have good leadership and team building skills. And Dr. Amresh said that the purpose of the boot camp is to create the captains of the ships. It's my privilege to talk to all the future cardiac surgeons here who are going to take this specialty to much greater heights in the future. So with that, my talk is more of a motivational talk, and it's not going to be didactic. Dr. Sri Aurobindo first said that nothing ever can be taught. Everything can only be learnt when you explore and experience yourself. So if you are feeling bored, I can skip straight to the last slide and finish it off if you want. These are my disclosures. Post-op cardiac care these days is now being increasingly left to intensivists who are specialists in this field. But in the middle of the night, if somebody crashes, you should realize that it's the surgeon who is called first. It's not the chief intensivist. You have to go there and you have to open the chest, and if you are unlucky, you may have to declare yourself. So that's why it's important to have very good knowledge, very broad knowledge about what is happening to the child. And this begins not at the time of surgery, but in the pre-op phase itself. And I express my deep sense of gratitude to all pediatric intensivists who tolerate and work with pediatric cardiac surgeons. And that's my intensive care team at Rainbow Children's Heart Institute. These are my general thoughts. Like everything, the care of post-op patients begins pre-operatively and intraoperatively. So it is necessary to make sure that they are in the best possible shape before taking for surgery, which means that if you have a patient who is in gross failure with edema, this is not the correct patient to take to the theatre. You need to manage them medically, give them diuretics, make sure that they are adequately dehydrated, their volume loading is proper, and then take to the surgery. And patients who have viral prodrome, it's very common in small children to have some cough and this thing, and if you do elective surgeries on them, just because you have a free slot, they end up staying longer in the post-op. So it's very important to assess preoperatively what you're dealing with, and care for history of ALT. Can somebody say what ALT is? Acute life-threatening events. So if in a VSD child, the mother says that the child is having sudden episodes of apnea or not breathing, it means that the child possibly has some bronchial compression and bronchomalacia. So you need to investigate them carefully. So as everything, the basics play an important role. A proper history should be taken before proceeding with the surgery. Most important thing, if you want to be a pediatric cardiac surgeon, look at the echo yourself. You should know how to interpret the echo. As Dr. Rajani was telling, you should know how to approach the VSD, whether you have to approach through the tricuspid valve, through the pulmonary valve, through the aortic valve, or whether you need a ventriculotomy. So you need to have very good understanding of echocardiography before proceeding with the surgery. And most importantly, make sure that the echo and the clinical condition correlates. So sometimes you may have a child with small VSD but very symptomatic. This child could actually be having bronchiolitis. So if you think that the child is symptomatic because of VSD and operate, your post-op course is going to be much longer. Like one interesting example is that one of the cardiologists who joined me initially said that there is a child delivered and it's a supracardiac TAPVC diagnosed antenatally. There is increased flow in the SVC, the child is in failure, the RARV is dilated. And then something was not fitting. I thought that the pulmonary veins were opening into the LA side. And then you wouldn't believe, if I put a stent on the head, there was missionary murmur. So this child was actually having vein of Galen malformation. So, and similar thing, same thing happened with infracardiac TAPVC also. You can have an hepatic arteriovenous malformation, and the cardiologist can falsely interpret it as an infracardiac TAPVC. So in case of any doubt, and if you think that your clinical examination and the echo findings don't match, don't hesitate to get a CT scan for further confirmation. Coarctation is also very easy to miss, and always palpate the pedal pulse. Like in Hindu tradition, we are taught that always touch the feet. So all these children, they are like God to us. So you first approach their feet and touch them, and if you have a warm periphery and a palpable pedal pulse, most of the thing is good with those children. And most importantly, surgeries like war, the more you sweat in peace, the less you bleed in war. So what it means that if you plan and practice what you are going to do, your post-op course will be that much smoother. Intraoperatively, you should do a good operative procedure focusing on correction of pathology and myocardial protection, which is half the battle won. Always have a mental picture of the pathology to be corrected and the steps you are going to follow. And don't forget the phrenic and recurrent laryngeal now. If you damage a phrenic nerve in a child, this child is going to stay with you for a long time with diaphragmatic palsy, or you may have to end up doing a diaphragmatic plication. And if you injure the recurrent laryngeal nerve while doing a coact repair or doing an arch repair, this child is going to have feeding difficulties and might end up having aspirations and staying in the hospital longer. And as Dr. Rajni was telling, intraoperative TE is a very essential tool. And as surgeons, you should learn to do basic echo yourself and learn to interpret it. And most importantly, intraoperative, make sure that all the pathology has been addressed. Get step up RA, PA step up, make sure that there are no additional VSDs. Do epicardial echo or TE, and make sure that there are no residual issues. And if there are any, you have a plan how to manage it post-operatively. So pediatric cardiac ICU is like a practical lab where all the knowledge which you gain while you are doing your first and second year of MBBS is put into practical use. Your knowledge of anatomy, physiology, biochemistry, microbiology, pharmacology, all these are necessary to do a good, proper pediatric post-op care. Sometimes you may have to double up as a nutritionist, endocrinologist, nephrologist, hematologist, neurologist. So finally, what is more important is to have a good leadership and interpersonal communication and counseling skills. See, this is and most importantly, try to learn from other branches of discipline also. Like this, a team in UK realized that the pit stop handover is very efficient. So when you have a Formula 1 car stopping at the pit stop, within 7 seconds, these 4 tires have to be changed, the wiper has to be petrol has to be filled, and the car has to go. So it works very efficiently. So the lesson which you learned during this sort of pit stop handover, if you can implement it while shifting the patient to ICU, you can make your processes very efficient. Lot of knowledge which we gain in management and like aviation industry, this is increasingly being applied in post-operative setting for increasingly better outcomes. It is not the surgery which makes a difference, but all these additional things which are going to improve your outcome in the future. So this everyone has an assigned role. What the cardiologist should, what the anesthetist, what the doctor at the bedside, what the nurses. So if you have an assigned role, you will minimize mistakes. So these are the sort of clear handover from the team. The surgeon should know what was the diagnosis. The anesthetist should know what is the ventilation parameters. So all these things, but important, everybody should have an assigned role and they should know what to do. So once the child comes to post-operative ICU, do a very thorough assessment, review the operative findings. If you are the person in the ICU taking care of the child, you should know all the details. You should actually imagine the pathology and understand what has happened to the child, so that you can take proper care of the child in the ICU. You should have a ventilation strategy. You should know whether to sedate this child or not. You should do a neurological assessment, a nutritional assessment. Most importantly, you should know whether the child is having good cardiac output or not. Believe me, in spite of all the gadgets we have, one of the most important predictor of having a good cardiac output is a warm periphery and a good pedal pulse. There are a lot of other indicators like having a good urine output, a good mental status, low lactate levels, decent good blood pressure. So one thing I would like to highlight is having a very high blood pressure is also not a good thing. So this children can actually have problems. So what they have found is that they have increasingly applied this artificial intelligence and machine learning algorithms in the care of post-op patients. And the most important factor which they have found to be associated with sudden cardiac death in the post-op period is lack of heart rate variability. So what you would think is that if you have a child who is having very steady heart rate with absolutely no budging, this child is possibly stable. But what they have found is that this child is already working on the high level of sympathetic drive, and if the heart rate is not fluctuating with, say, with the movements of the child, or if the child is getting woken up, it means that this child is at risk for having sudden cardiac death. So when they applied this machine learning algorithms and saw all the data, it is the lack of heart rate variability which was found to be the most important predictor of sudden cardiac death in the post-op ICU. There are a lot of potential post-operative issues. It could be regarding fluid balance, metabolic, gas exchange, cardiopulmonary interactions, arrhythmias. I'll just briefly go through, and the most important thing is that early detection of low cardiac output syndrome. It means that your cardiac output is not enough to meet the metabolic requirements, and the most thing you fear as a surgeon or the doctor treating the patient is neurological complication. Children who develop low cardiac output syndrome, all the other organs can possibly improve and recover, but sometimes the brain gets cooked at the end of the whole procedure. So you have to be extremely alert when you are managing these children. And 6 to 18 hours after the surgery, when it's when the cardiac output is at the lowest. So this typically in the middle of the night, and that is the time when you have to be alert. And this is where having an alert bedside nurse is going to save your child. So the role of bedside nurse in the care of pediatric cardiac patient cannot be overemphasized. She is the most important person in the whole gamut of taking care of the patient post cardiac surgery. The most earliest sign of low cardiac output is, can anyone tell what is the earliest sign of low cardiac output? Any post MCH patient, guys? It's having an increasing core temperature. If your core periphery temperature, if you have a warm, hot head and a cool foot, it means that the child is in low output. If you have both warm head and warm foot, then that's not a worrying thing. But if you have a wide fluctuation or difference between the core and the peripheral temperature, it means that the child is going into low output, and if you don't act fast, this brain of this child is going to get cooked and you are going to land up in trouble. So meticulous serial clinical examination is the key to pick up early low output. Conscious level is also very important. Pedal pulses are very important, as I said. It is the gradient between the core and peripheral temperature which is a very, very important sign. There are a lot of other biomarkers, but these are all very late. Rising lactate level, low. Mixed venous oxygen is also a very important marker which is very underutilized. If in a child who is having very high temperature post-op, and if you find very high mixed venous oxygen saturation, it means that possibly the child is septic. So low cardiac output will always be associated with a low mixed venous O2, and the MVO2 can be used to differentiate whether you are dealing with a septic child or with a child with low output. So with regards to inotropes, there are no dogma because there is no strong evidence to support one inotrope over the other. But with increasing availability of big data, we may know which inotrope is good. Suddenly somebody says dopamine is good, somebody believes that dopamine is bad. But personally, whatever inotrope you use, you should monitor the child carefully whether the inotrope is doing good to the child or not. And you should be ready to change the inotrope if need be. So dopamine, epinephrine, norepinephrine, these are all things which you can read up in your books, what they do, whether they're alpha agonists, beta agonists, what dose. So milrinone is also one of the favored inotrope. And of late there has been study where they say that milrinone use in tetralogy actually increases the fluid requirement, and it's not a good inotrope for use in tetralogy post-surgery. So they say epinephrine, norepinephrine is good enough. So you avoid fluid loading them in the post-op period. So this is an evolving thing, and you cannot have a dogma that no, only this inotrope is best. You should tailor your requirement according to the patient. And I have seen people sort of fight over this. They are sort of very religiously attached to their inotropes. People end up fighting over the inotropes. But whatever inotrope you use, I would request you to see whether it is doing good to the patient or not, and monitor the patient carefully. So once you land up in low output, what you should do is hypothermia. The temperature needs to be cooled urgently and immediately. See if you can pace and manage this thing. If you have a PD catheter, start early peritoneal dialysis. Sometimes thyroxine can help. And if you are the surgeon, you can open the chest and do a delayed sternal closure. In fact, in a recent study of all neonatal cases who landed up in acute kidney injury, they found that having an open sternum was a protective factor. So if you are in doubt and if you suspect low cardiac output syndrome, if the CVP is high, don't hesitate to open the sternum in the ICU. Leave it open for 1 or 2 days. This is going to help the child. And finally, if nothing works, you have to start mechanical circulatory support, which is not a practical thing in most setups in our country. So fluid and electrolytes are also important, and like inotropes, there are no strong recommendations with regards to fluid and electrolytes. There are all institutional based protocols, but by and large, in the first 24 hours after cardiopulmonary bypass, the fluid requirement is less. Normal saline is the most common fluid used, but there is increasing evidence that normal saline is not a very good replacement of fluid. It can cause kidney injury or increasing fluid overload and increasing risk of sepsis. They recommend balanced salt solution, either a plasmalite or a ringer lactate to use as a fluid replacement. But normal saline is not very bad if you want to use. The second common fluid colloid requirement is replacement, which we use as albumin. But what is important is that whether the child which you are looking after needs fluid or not. And you need to there are various ways to determine the fluid requirement. Of all the this is a persistent discussion in all pediatric critical care circles, how to assess fluid requirement. There are a lot of methods, and increasingly ultrasound is playing a very important role. They look at the ICU IVC diameter to say whether the child is going to improve with fluid replacement or not. Of all the different methods, passive straight leg raising is the most simple and easiest method to follow, because when you raise a leg by about 30-45 degrees, in an adult you give about 200 to 300 ml of bolus to the circulation, and if you see that the blood pressure is improving, it means that the patient requires more fluid. The advantage with this technique is that you are not fluid loading the system if the patient is already on the top of Frank-Starling curve. So the moment you keep back, the fluid is going to come back, and you can decide whether to give more fluid to the patient or not. There is a lot of discussion on using stroke volume variation and pulse pressure variation to see whether fluid requirement is necessary. So you can refer to that. But in small children, what we do is we just press on the abdomen and see whether that little additional bolus helps in increasing the cardiac output or not. All this is important because if you give additional fluid to a myocardium which is already struggling, you end up fluid loading the child. This child is going to stay longer in the ICU with increased risk of sepsis. So in fluid management, it is absolutely essential to make sure that you are not underfilling the child, neither are you overfilling. That the child is just adequately filled. And if you have a CVP of around 6, 7, 8, and if you have a good cardiac output, you are good most of the time. So it is usually about the average fluid requirement is about 60 to 75 ml per kg on the day 0, and gradually it is increased. In patients with very small LA, avoid rapid fluid boluses. These are especially true in cases like post-TAPVC correction or children who have LV dysfunction. You should be very careful while doing fluid boluses in them. In some surgeries like Fontan surgery, you need to give more fluid in the post-op period, especially when you do a BT shunt or an off-pump repair to maintain their appropriate hemodynamics. What is increasingly being realized is that using noradrenaline or vasopressin in this situation is not very bad to maintain the pressure rather than loading them with more and more fluids. So albumin is useful, especially when you use it on pump. In small children, when you end up having less edema at the end of the procedure. But clinically, there's a lot of debate whether you should use albumin or not in the post-op as a colloid. Use it only when the albumin is less than 2.5 gram per deciliter, And sometimes if you have low urine output with low albumin, if you combine furosemide with albumin, they tend to respond better. Cardiac tamponade can happen when there's either blood or fluid in the pericardial space. I'll just go through this. It can be bleeding, so one important point regarding cardiac tamponade is that, and one practical thing which I found useful is that when you suspect that there is cardiac tamponade, what they end up doing, or if you have a high CVP and say if the blood pressures are falling, the normal reaction of most ICU thing is you start a bag and start ventilating very vigorously this kid, which possibly can cause more tamponade. So what you do is, if you think there is sudden bleeding, you deflate the lungs completely, and if you open the pleura, some of this blood which are accumulated in the pericardial space can run off to the pleura, and you can possibly avert a very sort of disastrous situation. So if you have bilateral pleura open, and if you think that the child is having cardiac tamponade, you disconnect the ventilator briefly so that the lungs fall off, and if there is additional fluid in the mediastinum, it just runs off to the pleural space. So clear indications when to re-explore. If you have a child who is bleeding more than 10 ml per kg per hour, or if it is more than 5 ml per kg per hour for 3 consecutive hours, you need to take this child back and see what is happening. With regard to diuretics, furosemide is better. There are other choices. Metolazone can be used. Sometimes some of the kids are very alkalotic after using a lot of furosemide, and if you still need to use diuretics on them, acetazolamide is not a bad choice. And whenever in doubt, early institution of peritoneal dialysis helps. And vasopressin is increasingly being favored to prevent and treat capillary leak in these children. The pulmonary hypertension. So every year there is a World Society of Pulmonary Hypertension. They decide to sit together in a nice place and formulate guidelines. Most of them are not practically useful. So according to the latest definition, more than 20 millimeters mercury is the definition of pulmonary artery hypertension, and having more than a PVR of more than 2 to 3 Wood units. A different classification, but most don't help. But as Dr. Thomas was telling, that it's very important to understand the feeling of what the pulmonary vascular resistance is of the child before you close the VSD. If you close a VSD in a child who is already having Eisenmenger's, you are not doing good to this child. This child, who may have lived longer, you would have reduced the life expectancy of the child, because this child can die suddenly. So as a pediatric surgeon, you should be very clear whether you are doing good to this child, and if in doubt, possibly it is better not to operate, because the natural life history of an untreated Eisenmenger's is not very bad. As Dr. Thomas was saying, they survive up to 30-40 years. But if you close a VSD in a child who has Eisenmenger's, you shorten the life expectancy of the child. So so a lot of new drugs are there in the market. I'll just mention briefly so that you can look it up later. Sotatercept is a new drug which is available. It's a drug which is a fusion protein. It's not still available, but it can be made available in the future. So it acts like a ligand trap for a protein called activin, and it is now approved for adults. So this can probably soon be used in children also. Selexipag is a new pulmonary vasodilator. The advantage is that it's an oral drug and it is cleared for use in pregnant patients. So only 2 drugs can be used in pregnancy which are pulmonary vasodilators. One is sildenafil and other is Selexipag. Both endothelin receptor antagonists, the bosentan and ambrisentan, and the other drug is not recommended. Riociguat is not recommended in pregnancy. Imatinib is also tried. This is a very interesting molecule which was developed after studying the 3-dimensional structure of the tyrosinase kinase protein. They did computer modeling, and after thorough put sequences, they designed this molecule structure, and it's been found to be very, very useful in lot of conditions which was initially thought to be untreatable. Like in chronic myeloid leukemia, this small molecule has increased life expectancy from 30% in 1903 to almost near normal life expectancy in children with CML these days. So, and the reason why it is being used in pediatric cardiac surgery is that it is supposed to reduce fibrosis. And people are hopeful that using this in pulmonary venous stenosis, you can possibly reduce the amount of fibrosis and help these children, but the final result is not yet out. But it's a very, very interesting molecule. And the advantage is that it's available orally and it's not very costly. And most of the oncologists have got very good experience with imatinib. Riociguat is increasingly being pushed in adults with heart failure as a pulmonary vasodilator. It's a soluble guanylate cyclase stimulator, and it can be used with bosentan. And as I said, it's got very high risk of teratogenicity, and it's not used for children. It's used for pregnant lady. So cardiopulmonary interactions are it's a very interesting thing. But the take-home message is that if you have a child who is having a good left ventricle and a bad right ventricle, they'll do better if you extubate them. Like, in fact, conditions like Fontan, what they have seen is that if you extubate a child with Fontan, their cardiac output increases by almost 50%. So after any two ventricle repair, when you are waiting for all lactate to settle down and acidosis to correct, but for a post-op Fontan patient who is a little acidotic and lactates are little high, if the patient is breathing spontaneously, just extubate them. So they'll do much better post-extubation, especially the single ventricle patients. So it's very important to understand this, how to use this cardiopulmonary interaction to our benefit when you are managing children in post-op care. A lot of criteria for extubation, it can vary depending on your protocol. See, whenever there's a weaning or extubation failure, there are a lot of other things which you should go across and check whether they are all right or not. Most importantly, you should see whether there are any additional defects, any pulmonary defects. And this an ultrasound of the chest. The POCUS thing is increasingly being used in ICU care setting, and having a very good knowledge of POCUS would be helpful to avoid X-rays completely in your post-op ICU. If you have a very good knowledge about ultrasound, in fact, there are studies which show that it's as good as CT scan in assessing pulmonary pathology. I'll talk about POCUS a little later. So, no points for guessing what this child is having. What is this? Okay. So this child had a left diaphragm palsy following TAPVC repair. So in TAPVCs, you tie off the LSVC, and the left phrenic is very close to the vertical vein. And what I have noticed is that sometimes when you use silk to tie off the vertical vein, this can cause delayed fibrotic reaction. I have had two kids who had developed delayed diaphragmatic palsy, and after that I have stopped using silk to ligate the vertical vein. I prefer to use either a Prolene, or if a small piece of Gore-Tex is available, I use that. So, so one take-home message was that don't use silk when you are ligating the vertical vein in very small kids. The fibrotic reaction around that vein can sometimes damage the phrenic nerve, which is very closely related to the vertical vein. So there are a lot of other things which you need to go through when you are having an extubation failure. Hypotension, acute desaturation. Most importantly, make sure that there is no kink in the ventilation circuit, and it's not a pH crisis. And importantly, when it's a post-op BT shunt child, and if you are seeing acute desaturation, should act immediately. And recently I had a situation where I did a shunt, and this child had some limb issues. What had happened was the venous cannula which was placed in the leg was displaced, and they were giving blood through this venous cannula. And this blood had extravasated in the limbs, causing almost like a compartment syndrome in a small child. This child was 3.5 kilo old. And so this was realized when the child was shifted to the ICU. We saw that the leg was extremely stiff, and we thought that the child is going to land up in compartment syndrome of the leg. We took the child back to the theatre for doing a fasciotomy. We had called vascular surgeon to get his opinion, and we were waiting. But during this time, what we noticed was the saturations dropped suddenly, and the child had developed bradycardia. So since the child was already in the theatre, we opened the chest immediately, and we found that we milled the tube. The BT shunt was patent, but the saturation did not pick up. So we put this child on bypass and opened the thing. What had happened was, I had used a small pericardium for LPA plasty, and a small amount of clot, very, very soft clot, had formed inside, and this was blocking the flow. So I was surprised to see the softness of this material and the acutity with which the whole situation can develop. The child desaturated right in front of our eyes, and what I found was very, very soft clot. So the take-home message was that if you see sudden desaturation in the post-op BT shunt, you need to act immediately. You need to increase the pressure. You can give a heparin bolus. What we used to do in our ICU was have a cuff on the right arm and keep it inflating intermittently at every 1 or 2 minutes, so that you provide afterload to the shunt and the flow through the shunt increases. So once you cross about 12-24 hours period, the shunt would be stable and it would flow well. But the initial 3 to 4 hours is extremely crucial following a BT shunt, and you need to be very when you are managing these patients. And if you delay acting on that, this small soft clot can become a big clot and totally block the shunt. So increased work of breathing is a concern, especially in an extubated patient. The take-home message is that if you are not happy with any child, don't hesitate to re-intubate. More lives are lost trying not to intubate rather than intubating electively. So if you are a junior resident or a doctor managing an ICU, and if you feel that in the middle of the night the child is not breathing well, you don't bother about disturbing a consultant or your senior. It is safer to intubate this child, rather than waiting for this child to get exhausted and in the middle of the night arrest. So one important thing I would like to share is that in post-op ICU, sometimes you have a child who just wakes up from anesthesia and is very agitated. The common reaction is that if you are not trying to extubate the child, you sedate and paralyze the child. What can happen sometimes is that the endotracheal tube could have been displaced during the process when the child was struggling. And I have seen a situation where a child who had a routine tetralogy repair was doing well, had woken up at 12 o'clock. But the doctor on duty said, no, we'll extubate in the morning, you sedate and paralyze the child. The child was sedated and paralyzed, and at 3 o'clock the child had bradycardia and hypotension, crashed. So what was realized was that the tube had displaced during the period when the child had actually woken up and struggling, and nobody realized it, and the child was paralyzed. So the child gradually developed hypoxia over a period of time and crashed. So whenever you are paralyzing a child, especially who was struggling, make sure that your endotracheal tube is in proper place. Arrhythmias. Of all common arrhythmias in post-op pediatric ICU, jet is the most common thing which you are worried about. Arrhythmias are very common following cardiac surgery. The most important thing is that how you handle the tricuspid valve during the surgery. If you pull the tricuspid valve and retract it very sort of forcefully, you are going to land up in trouble. And believe me, when you constantly tell your assistant, or when you are the assistant yourself, the idea is not to pull, the idea is to retract. So be very, very gentle when you are retracting for your surgeon, for exposure of VSD, or any purpose. Be extremely gentle and delicate, and that can help reduce most of the junctional tachycardias which you see in the post-op period. So this is very common following tetralogy of Fallot or AV canal defects, and you have high heart rate. The first thing is to cool. You give magnesium, and then most commonly we use amiodarone. But these days sotalol is also increasingly being used. They say that it acts more rapidly. And ivabradine is also very, it's a new wonderful drug for this purpose. And lot of jet, they respond very well to ivabradine if they are not responding to amiodarone. Ivabradine is also a very interesting molecule. It inhibits the funny current that involves this hyperpolarization activated and cyclic nucleotide gated channel. The disadvantage is that only oral formulation is available. But this acts within half an hour to 1 hour after you give it orally. So high grade fever, I told you, you have to be very, very wary that whether it's a sign of low cardiac output. Renal replacement therapy. So peritoneal dialysis is very commonly used in children. There is an X-ray at that right hand side. Can somebody say what that X-ray is showing and why did I put it up here? Any takers? What is that X-ray showing? I understand that you are all hungry. So what is happening? Can you see the air under the diaphragm sort of thing there? So what is this sign? It's called a Chilaiditi sign. When your large intestine goes and gets anterior to the liver, and it can sometimes mimic as air under the diaphragm. The reason why I'm putting this in renal replacement therapy is that this has happened with me. Intraoperatively, when you open the peritoneum through the sternotomy to put the PD catheter, sometimes this large colon can come. You can mistake the large intestine as a peritoneum, open it and then put the PD catheter inside the large intestine. So whenever you open the peritoneum, you should be able to see the liver. And if you're not seeing the liver, don't put the peritoneal PD catheter through the mediastinum. You may sometimes be opening the colon and doing no harm to the patient. So hyperkalemia, there are very sort of standardized established protocols how to manage it. I'm not going to bore you with that. Neurological issues are very common in pediatric heart surgery, and that sometimes can be very morally demotivating. When you do a good surgery and if you see a child which is not awake or the brain is cooked due to low cardiac output syndrome, this is a very devastating complication. And this sometimes which you still don't understand. But using nurse, basically you have to be very, very careful making sure that the child's brain is getting proper blood supply during the whole process. Seizure management. Seizure is pretty common in the post-op period, but seizure as such is not a very bad prognostic sign. If you have just one isolated seizure, they respond very well to anti-epileptics. Their prognosis is also not very bad. It is more dangerous to see a child who never wakes up at all than to see a child who is having a small seizure at the end of surgery. Nutrition is very, very important, and one of the most common mistake we do in managing nutrition is that we don't lay a lot of stress on this. And a lot of children are unnecessarily kept NPO. They are kept NPO before extubation, they are kept NPO after extubation, they are kept NPO before any procedure. So make sure that any child in the ICU is not unnecessarily kept NPO. Sepsis can be the final blow to a very good surgery. You can do a very good surgery, but if the sepsis comes in, it can sort of undo all the good work you have done in the theatre. CRP and procalcitonin is increasingly used as a good biomarker, and if you have elevated CRP in a neonate with a very complex heart surgery, you wait for CRP to settle down before taking the child to the theatre. So the important thing is to recognize sepsis early and act early. And most of them, early sepsis presents as an increased pulmonary vascular resistance. One of the earliest subtle signs in small children is they don't tolerate feeds. So if you have a child who is doing well, not very active and not tolerating feeds, sepsis should be in the high in the list of possibilities in that child. So sepsis management, lot of antimicrobial therapy is being used for sepsis. So using antibiotics for treating sepsis is like using bullets and guns for targeting terrorism. You can possibly temporarily control it, but you can never sort of eliminate it. So of late, what we have been doing is that all children we are using probiotics in the pre-op period itself. So you feed them with enterogemina, which is bacillus, friendly bacillus, or bifilac. You replace the entire system with friendly bacteria so that there is less chance of all this pathogenic bacteria to overgrow, this Klebsiella, Pseudomonas and all that. It's been shown to work in very low birth weight children, but hopefully it will help in other children also who come to the ICU and get infected with all these bad bacteria. So hand hygiene is the most important factor to prevent sepsis. Post-op bleeding, hemolysis can be a... So there's a very interesting thing regarding hemolysis which was realized only during the COVID period, is that free hemoglobin, so if you have a hemolysis, it's a very bad thing. Free hemoglobin present in the blood can cause lot of harm. This life-saving molecule, when it gets out of the RBC and it's present in the plasma as a free hemoglobin, what it does is that it does a lot of harm. It can bind nitric oxide. So once you bind nitric oxide, they have very high pulmonary vascular resistance, their blood pressure increases, they end up having neurological problems. This is a common thing which you might have noticed whenever you have seen a patient on ECMO, is that they are hypertensive. On day 0 they are normotensive, and then gradually over a period of time they become extremely hypertensive, and possibly this hemolysis due to ECMO and the free hemoglobin has got a very important role to play in that. And identifying this free hemoglobin is important. But unfortunately, there was no proper lab estimation to identify this free hemoglobin. But what they realized is that all the automated blood analyzers which we have, it gives a value called hemolysis index, which tells you whether the sample which you have is a good sample or not, or whether you need to repeat the investigation. So this hemolysis index, which is available in all the automated lab machines, can be used as a surrogate of hemolysis. And if you request the lab, you can find out how much hemolysis has happened when you ask them what is the hemolysis index of that machine is. So TEG and ROTAM is, you can use it increasingly bedside to so that you have rational use of your blood products when you're managing them. So point of care ultrasound is increasingly coming in a big way in managing of ICU patients. So the doctors of tomorrow will definitely be seeing the lung with the ultrasound. This is what a quote by one of the doctors, Dr. Daniel Lichtenstein. He's considered the father of ultrasound. The point I would like to lay stress on in this lung ultrasound is that initially when they put the probe on chest wall, all you used to see was a series of artifacts. But what this guy did was, all these artifacts has some meaning in itself. So if you analyze the meaning, you can come up what this child is actually having. And if you learn proper bedside ultrasound, you can eliminate the need of X-ray in ICU setting. So this is called actually semiology, like making sense of different signs to indicate what is actually happening. And this is how medicine develops, because you see a elevated JVP or a big liver, you know that the child is probably has got a congested heart. So you look at different signs to find actually what is happening. So using lung ultrasound is also very similar to that. So you see artifacts and try to find out what is happening to the lung. This is a separate thing in itself. Possibly, hopefully, we'll conduct a workshop so that we can all benefit from using lung ultrasound. So all this B lines, A lines and all make sense when you start using a lung ultrasound. The different very interesting signs, the bat wing sign, the common tail artifact, the seashore sign, the barcode sign. This means they have a pneumothorax. So this can be rapidly be used in bedside sitting to decide what you need to do. So my parting thoughts: the best post-operative monitoring tool is a vigilant bedside nurse and an attentive and alert duty doctor. The post-operative course to a large extent depends on pre-operative planning and intraoperative execution. Taking the child to theatre and leaving the theatre with the best physiology possible and attention to perfusion and myocardial protection is the key for a smooth post-op course. Low cardiac output and its neurological effects needs more scientific research. With artificial intelligence and machine learning, a day is not far off, and most of the ICU management can be automated and bad outcomes can be predicted in advance. Sepsis and antibiotic resistance is a big killer for which we need to find our own solutions. And we need to acquire skills in echocardiography, POCUS, and don't hesitate to enlist the help of specialists when in need. Always work together as a team and develop very good interpersonal communication and counseling skills. And I would like to ask you, do you know what this Ishikawa fishbone diagram is? Anyone? Ishikawa diagram. So Ishikawa was a German engineer, and this was singularly responsible for how Japan, or it's a Japanese engineer. Why?
Name looks like Japanese.
Yeah, so sorry, it's a Japanese guy, and this guy was responsible for how and why Japan became a manufacturing powerhouse after the Second World War. So it's called a fishbone diagram. At the head of the fish, you have the problem that needs to be solved, and as various ribs and tail of the fish, you have different things which you can work on. They focus on 5 Is: the man, the machine, the method, the material, and the measurements. So applying this in all that production thing, Japan became one of the where you can rest assured that if something comes from Japan, it will be of good quality. It's a process of continuous quality improvement where you very objectively look at what are the factors which are going in improving your production or the process. So same thing when you apply for your ICU thing. If you have a problem, you see where you can act. If you have a fishbone sort of diagram, it can help improving your performance. As I said, all these things which are used in management is increasingly being used in intensive care setup, like PDSS cycle: plan, do, study, and act. So all these things have one thing in common: Don't blame others for whatever happens. You look inwards and try for continual improvement. So finally, still the best marker for good cardiac output is good pedal pulses and warm peripheries. For a good ventilation is a good chest rise, and for a good neurological status is an awake and interactive patient. I should tell, recently there was a child who had a PDA closure, and this child was not waking up. It was a device PDA closure. This child was not waking up in the post-op. The child was very drowsy. When you wake the child up, the child will just wake up and then again sleep. So the ICU team was not happy, and in the middle of the night we got a CT scan done. The child had actually intraventricular hemorrhage. The child underwent drainage and immediately improved. So